Hi, I'm Dr. Kishika Koirala, MD Radiology. Let's begin some radiology core exam questions and let's discuss them together. Okay, the first one. Here is a delayed GAD enhancement cardiac MR of a patient complaining of persistent chest pain. What is your diagnosis? Cardiac MR is high yield topic for board exams, for core exams. All right, so your options are myocarditis, myocardial infarction, sarcoidosis, amyloidosis. Let's go to the picture once again. So this is an image. So what do we see? There is late gadolinium enhancement in the lateral left ventricular wall, right? Almost in the mid part of the left ventricle towards the apex, there is late gadolinium enhancement. The enhancement is not transmural, it's most likely subendocardial, meaning below the level of endocardium. So late subendocardial enhancement in a patient with persistent chest pain, my best bet would be myocardial infarction. Yeah, so the answer is myocardial infarction. Just a quick review. There are different causes of delayed GAD enhancement on cardiac MR. This is a high yield picture, pops many times. Subendocardial infarction, subendocardial enhancement, seen in subendocardial infarction, like the one that we just saw, or transmural infarction, or can be also seen in cases of amyloidosis or systemic sclerosis. If it is infarction, it will involve certain vascular territory. If it's amyloidosis, it will be circumferential, right? If there is mid-wall delayed GAD enhancement, you might want to think of maybe there's right ventricular overload. And what is the most common cause of right ventricular overload? One of the most common causes is hypertrophic cardiomyopathy. If there is mid-wall one, but it is rather more involving more of the circumference, could be myocarditis or could be dilated cardiomyopathy. It can also be seen in cases of sarcoidosis, myocarditis, and Chagas disease. Epicardial delayed GAD enhancement, on the other hand, can be seen with sarcoidosis, myocarditis, Chagas disease, and Anderson-Fabry. Now, of all these, of course, these all are important, but I would like you to focus on subendocardial enhancement, okay, which can be subendocardial infarction, transmural infarction, amyloidosis, sarcoidosis, and hypertrophic cardiomyopathies. These are high-yield ones. Okay, the next one. Which of the following, in which of the following ILDs is smoking not a risk factor? UIP, meaning usual interstitial pneumonia, NSIP, RBILD, respiratory bronchiolitis ILD, and DIP, desquamative interstitial pneumonitis. So UIP is associated with smoking, more commonly seen with smokers. RBILD and DIP are two ILDs which are strongly associated with smoking. So my best bet is 2 NSIP. Yeah, so the correct answer is NSIP. Let's do a quick run of these options. So this HRCT image that is a comparison of HRCT features between UIP and NSIP. See, this on the right side is UIP. You see honeycombing on the subpleural side. there will be honeycombing, right? Honeycombing with reticular opacities, tractional bronchiectasis. So honeycombing with tractional bronchiectasis, always think UIP. Whereas the the left one is NSIP, where you see homogeneous enhanced or homogeneous involvement with predominance of ground glass opacities. You see GGOs and you see subpleural micronodules. Most commonly, you see small nodular opacities. And even if honeycombing are present and can be present in NSIP, they are rather microcystic and not macrocystic as compared to the honeycombing in UIP. Okay, so UIP, you want to think of macrocystic honeycombing and tractional bronchiectasis, whereas in NSIP, you want to think GGOs, micronodules, and microcystic honeycombing. Okay, this image, this set of HRCT images are the images of RBILD. See, we see fine centrilobular nodules distributed throughout the long parenchyma, right? So these are the features of RBILD, quite non-specific to be, to put it as so. Now this one, on the other hand, it is DIP. It is desquamative interstitial pneumonitis. It is rather a grave finding with a poor prognosis. You see subpleural ground glass opacities and ground glass consolidations, microcystic areas. You can also see peribronchovascular microcystic lesions, as you can see, in ground glass opacities overall, and cystic lesions. This is not salvageable for poor prognosis. So this is your DIP, okay? DIP, RBILD, UIP, NSIP. Among these, NSIP is not associated with smoking. Almost all three are. Okay. What artifact on ultrasound is helpful in identifying renal calculi is the question. So, the options are reverberation artifacts, twinkling artifacts, mirror image artifact, and posterior acoustic enhancement. Let's go by the options one by one. So the answer is twinkling artifacts. This is your reverberation artifact. Now, reverberation artifact, it occurs when ultrasound pulse, it is trapped between two strong parallel reflectors, right? The wave reflects back and forth between the strong reflectors, and the waves that return to the transducers are interpreted as coming from the deeper structures since they arrive to transducers rather late, right? So reverberation artifacts can arise anytime you image any imaging finding between two strong reflectors. That is the case. Here in this image, you see reverberation artifact from skin surface while using a standoff gel pad, right? Okay. This one is easy one. This is twinkling artifact. Twinkling artifact is seen with color Doppler ultrasound, right? It occurs, you can see it as a focus of alternating colors on Doppler signal behind a strong reflective object such as calculus. It gives the appearance of turbulent blood flow. It appears with or without an associated color comet tail artifact. And in fact, this is the most most specific artifact that can help us in identifying the renal calculi. It is not posterior acoustic shadowing, okay? It is the twinkling artifact. It is the most specific artifact for diagnosing calculi on ultrasound. Here you see there is posterior acoustic enhancement or increased through transmission is the other name, where there are increased echoes deep to the structures that transmit sound so exceptionally well, right? And this is a characteristic feature of fluid-filled structures such as cysts, urinary bladder, and gallbladder. So this is posterior acoustic enhancement. This is a mirror image artifact. It is seen when there is highly reflective kind of surface in the path of primary beam. See, there's a rather reflective surface on the path of primary beam, because of which there has been production of this mirror image artifact of right testicle, right? So this is mirror image artifact. Okay. The other case, what is the diagnosis in this contrast enhanced CT? Superior mesenteric artery syndrome, nutcracker syndrome, median arcuate ligament syndrome, May-Thurner syndrome. So here, see, what do we see? What do we see is that there's compression of the left renal vein between the superior mesenteric artery and aorta, right? This is superior mesenteric, this is nutcracker syndrome. Nutcracker syndrome is a vascular compression disorder. Mostly you see compression of the left renal vein between superior mesenteric artery and aorta. We can always have other variations. It can lead to renal venous hypertension, and it can also lead to the rupture of thin wall veins into collecting system with the presenting symptoms of hematuria, right? So that is your nutcracker right there. Okay. This is because your renal vein is compressed between superior mesenteric artery and aorta, like the nutcracker with a nut. It is called nutcracker syndrome. SMA syndrome, on the other hand, is also known as Wilkie's syndrome or aortomesenteric duodenal compression syndrome. It's also a vascular compression disorder in which there's acute angulation of superior mesenteric artery, and because of this, there's compression of third part of duodenum. As you can see, third part of duodenum is compressed because of the angulation of superior mesenteric artery, leading to obstruction in D3. There are a few values for diagnosing it. For example, normal value of aortomesenteric angle, it is 28 to 65 degrees. In SMA syndrome, it is rather reduced to 6 to 22 degrees. Aortomesenteric angle, okay? So this is a case of median arcuate ligament syndrome, also known as MALS. Median arcuate ligament it's a fibrous arch. It connects left and right diaphragmatic crura at the level of aortic hiatus. If there's low-lying median arcuate ligament, it can compress the celiac axis, and it can cause celiac artery compression syndrome, which is also known as median arcuate ligament syndrome. So this is one of our publications in ECR 2020, Abdominal Vessels, Subtle Things to Look for Before Labeling Normal Study. This is our DOI. You can always go over this link to go further, to study further on abdominal vessels. Okay. What is the most common location of encephalocele? nasal, occipital, parietal, or basal. So the most common location of encephalocele is occipital one, right? See, this is an MR image, SAS1, showing occipital encephalocele. It can be associated with a number of anomalies like Kyrie malformations, Dandy Walker malformations, etc. Here you can see a defect in the occipital bone, and there's a herniated sac. There's herniation of occipital lobe. There's herniation of occipital horn of lateral ventricles. There's herniation of fourth ventricle and all. It represents, in fact, meningoencephalocele. Okay. What is the most common site of pulmonary sequestration? Right upper lobe, middle lobe, right lower lobe, left upper lobe, left lower lobe. So the most common site of sequestration, pulmonary sequestration, is left lower lobe. What is sequestration again? Pulmonary sequestration, it's an accessory lung. It's a form of aberrant formation of segmental lung tissue. This has no connection whatsoever with the bronchial tree or pulmonary arteries. It's a type of pulmonary bronchopulmonary foregut malformation. There are two kinds of sequestration, lung sequestrations. You might want to keep that in mind: intralobar sequestration and extralobar sequestration. The most common one is intralobar sequestration. Almost 85% of all is intralobar and presents later in childhood with recurrent kind of infections, right? So that's your intralobar sequestration, most common in left lower lobe. Okay. Which of the following is most likely diagnosis? Psoriatic arthritis, reactive arthritis, gout, OA, or all of the above? Okay. So I think it's all of the above. Yeah. See, this is a coronal PD fat-sat image where you see there's bilateral asymmetric edema within bilateral sacroiliac joints. Most commonly, it is seen with osteoarthritis. However, patient's clinical history and symptoms are very important for diagnosis. Okay. Gout, psoriatic arthritis can also cause asymmetric sacroiliac joint involvement, usually bilateral one. RA, ankylosing spondylitis, IBDs, or inflammatory bowel diseases, they are also related to bilateral and symmetric sacroiliitis. We have a mnemonic of PAIR pair, where A and I, that is ankylosing spondylitis, and IBDs, they are symmetric, right? Whereas psoriatic one and the Rita's one, they are asymmetric patterns of disease, okay? So that's your pair. Which of the following is demonstrated in the image below? Mucoid degeneration, grade 2 ACL tear, chronic grade 3 ACL tear, or ACL ganglion cyst. So here you see this is a SAS fat-SAT image. You see severe mucoid degeneration of ACL, anterior cruciate ligament. This can be the result of chronic repetitive trauma over a patient's lifetime, or it can even be age-related degeneration, right? In addition, congenital or acquired synovial tissue may be entrapped between the ACL fibers and give this appearance. So mucoid degeneration, in fact, is a rather common entity, and it should be familiar to avoid calling this ACL injury or ACL tear. In fact, on MRI, the ligament, ACL ligament, it appears rather thickened and inhomogeneous, and they are said to resemble celery stalk or drumstick appearance, and they are most often associated with ganglion cyst of ACL, however, not shown in this image. Therefore, your most likely finding and the answer here is mucoid degeneration. Okay. So these all are the cases for today. For tomorrow, we'll come up with more cases. Thank you.